which is Miss Manjari Chandra, and she's from India. Welcome, and we would like to hear what you have got to say to us today. Thank you.
Yeah, hi. It's afternoon in India now. It's post lunch time, but I know that it's morning in London. So hello to everybody from India. My name is Dr. Manjari, and I practice functional nutrition essentially with a couple of large hospitals in the capital of India, which is called Delhi. Am I audible enough, please? Can you hear me well? Can you hear me well, Dr. Tele? Am I audible, please, the organizers?
Sorry, I can hear you very clearly. Sorry,
okay.
I muted.
Okay.
But yes, we can hear
so
you.
I live in India in a city called Delhi, which is the capital of India, and I work for 2 large hospitals here. I practice functional nutrition, and it's my privilege to be among everybody today, and thank you for the invitation. Essentially, my scope of work is more in the space of functional nutrition. And as we understand today that functional medicine is the type of medicine where we are using modern medicine to sort of put diseases into remission, which means that instead of using pharmacology to address symptoms of diseases and manage diseases, we are using the modalities of epigenetics, the modalities of lifestyle, the modalities of nutrition, stress management, and integrative medicine essentially to put diseases into remission. And that's what my type of work is. So I work more in the preventive and treatment modality, but not using pharmacokinetics, and of course using modern science. So it's all driven by modern science, inspired by somebody called Dr. Mark Hyman, who is the director of Cleveland Clinic and a functional medicine practitioner, and from Institute of Functional Medicine. I will today be presenting something on the remission of diabetes, which means that, with diabetes being, most of the time when patients walk into clinicians, they're told that it's a lifelong disease and they have to learn to live with the disease and learn to manage their blood sugars. However, what I'm going to talk about today is more about how to sort of conquer the disease or put the disease in remission. That's what I'm going to talk about. Specifically,
excuse me, Miss Manjari. Would you like to share your presentation with us?
I'm going to share
this. Click on the share button.
Yes, absolutely.
There you are.
Yeah. So
thank you.
Yeah. So as I was saying that this is about the remission of diabetes, and specifically today I'll be speaking about type 2 diabetes, which is not non-insulin dependent diabetes, which is more degenerative, and age-related diabetes, which is more a cardiometabolic syndrome, really part of the cardiometabolic syndrome in itself. So if you see, diabetes per se originates from 2 major factors: inflammation and insulin resistance. And although people talk a lot about insulin resistance, I really wanted to explain that the concept of insulin resistance is extremely simple. It's as simple as the food you eat, So when you're eating a lot of excess packaged processed food, which is simple carbohydrates with very little probiotic, prebiotic component to it, with very little soluble, insoluble fiber to it, it's simple carbohydrates, it causes the body to make a lot of insulin. That's a response to eating carbs. So when your body starts making more insulin. So when it starts making more insulin, the cells start resisting insulin. And I'll of course talk about the pathophysiology also, but the cells have they've started resisting insulin. They're not reacting to insulin. And therefore, whatever food or whatever carbs or sugars that you've eaten are now getting converted into fat. So instead of they being used up for energy, you have more fat storage, more adipose tissue buildup, more glycogen storage, more fat in the non-alcoholic fatty liver. So there is more fat storage. And At the same time, although you're eating well, you also feel tired and hungry because your adenosine monophosphate kinase, which is essentially what is required for the metabolic breakdown of sugar in the mitochondria via gluconeogenesis or even via the pyruvate cycle, that does not happen properly. So instead of food being used up to generate energy via the mitochondria, it's being stored as fat. And that's essentially what insulin resistance is. And we'll go through more of this. Now, what happens is in a normal insulin signaling, when you're eating food which has any form of carbohydrate in it. Now, many times when you're talking of sugar or glucose, the glucose is primarily not just direct sugar. It's also fructose, it's also lactose, it's also starch, it's also all forms of simple carbohydrates. So all simple carbohydrates, when they go into the blood, they're broken down into glucose. The glucose then, the concentration of glucose increases in the blood, and that it basically is the signal. It's like a mechanism or a feedback to the pancreatic beta cells in the islets of Langerhans to secrete more insulin. So the beta cells start making more insulin. When the beta cells start making more insulin, the insulin travels to the cells, binds to the insulin receptor, wherein, the glucose transporter, which is the GLUT1, it transports the glucose inside the cell via the cell membrane. Inside the cell, what happens is once the insulin insulin at the same time also activates the metabolic activity, which means it activates the IR, which is the insulin receptor tyrosine kinase, and it also works on the P13K and the AKT pathways. And these pathways, what are these pathways essentially doing? They create a regulation or activation of multiple cascades of metabolic pathways. These pathways include glycogen synthesis, fatty acid synthesis, the inhibition of apoptosis, autophagy. So cells that were supposed to die now survive because there is food for the cells to survive. And also they inhibit the conversion of fat and protein into sugar, which is called gluconeogenesis. And therefore, when the cell has enough glucose, this glucose is now used by the mitochondria via the glycolytic pathway, the Krebs cycle, and oxidative phosphorylation to get converted into to get the adenosine triphosphate to be made. So we know that the adenosine monophosphate changes into via the NADLF pathway. So that's the normal insulin signaling and the normal glucose metabolism that is happening in a person who's sort of non-diabetic and there is no insulin resistance. However, and that's how it happens. You see the insulin signaling, you see the cell wall, the endothelial cell wall, there is a receptor on the cell wall, the insulin receptor are transported by the glucose transportase, and they enter the cell. So the insulin does its bit of doing the AKT, wherein it starts the metabolic pathways, whereas the sugar itself is broken down via the glycolysis and the pyruvate pathway to release energy. This is what happens in a normal person who has his insulin working normally, and there is no insulin resistance, and there is really no diabetes mellitus existing. So this is a non-diabetic person. However, in people, when a person is consuming very high amounts of sugar on a daily basis, or the carbohydrate content in the food is very high, it eventually causes, as we discussed in the first slide, the overactivity of beta cells and the overproduction of insulin. So overactivity of the insulin eventually leads into insulin resistance. When insulin resistance happens, it essentially causes two things to happen. It changes the blood glucose into fat, causing the accumulation of adipose tissue in the body, leading to metabolic obesity. It also causes the increase of sugar in the blood, which is called hyperglycemia. And this hyperglycemia in the blood, when it stays for a very long time, eventually gets converted into type 2 diabetes mellitus. Also, this state of insulin, which is resistance and hyperinsulinemia, because not only is there more sugar in the blood, there is also excess insulin in the blood, which is hyperinsulinemia. this also, what it does is it eventually hurts the pancreatic beta cells, because the beta cells are on an overdrive to make excess insulin. And because they're creating excess insulin, the beta cell dysfunction happens. And if you look at the cardiometabolic syndrome, everything that is part of the cardiometabolic syndrome, whether it is hypertension, whether it is dyslipidemia, high TGs and high LDL and HDL and total cholesterols, high low density lipolipids, whether it is non-alcoholic fatty liver disease, whether it is autoimmune conditions such as multiple sclerosis or lupus, whether it is neurological disorders such as Alzheimer's in particular, or whether it is hormonal imbalances like PCOS in women, or the loss of libido in men because of less testosterone levels, or even neurological disorders such as autism or ADHD. All these cardiometabolic diseases, which fall in the space of the cardiometabolic syndrome, have their origin in something called insulin resistance, which means that our consumption of carbohydrate and excess energy consumption that we do in the modern urban setting that we eat today is actually the reason for every cardiometabolic disease. And therefore, the correction for multiple sclerosis or any other autoimmune condition is really not just the prescription of steroids or painkillers. It's more really into getting into the epigenetic behavior of that person and changing the modality of nutrition. And therefore, that's how nutritional science or functional nutrition can be used to look into the why of a cardiometabolic syndrome and eventually reverse that in some way. So that's essentially what the cardiometabolic syndrome is. And if you see, everything is sort of correlated to each other. So whether it is hypertension, whether it is high cholesterol, especially the LDL cholesterol and the very low density lipolipids, whether it is insulin resistance, whether it is, rheumatoid arthritis, atherosclerosis, whether it is any other form of malignancy, including tumors and cancers, whether it is renal failure, especially in chronic renal failure, all of it are connected to one common cause, which is insulin resistance and, of course, inflammation. We'll go to the next bit now, which is inflammation and how that's responsible for every cardiometabolic disease we see today. So if you look at this picture, you'll see that, when there is intra-abdominal obesity, especially visceral fat and fat inside the abdomen, not just outside, but also inside the abdomen, we also use a word called TOFI. So a lot of people who live thin outside and lean outside may have a lot of visceral fat in their body. So they're thin outside, but fat inside. So I'm concerned about the visceral fat of everybody, even if they may have a good BMI, and even if their body fat percentage is okay, and even if they look healthy and lean from outside, they still may have excess fat stored in their visceral cavity in the abdomen. So for people like those who have intra-abdominal obesity or visceral fat, what happens is that this leads to the increase in the interleukin factors, interleukin 6 and 8, which are essentially inflammatory factors. It also affects the way in which TNF-alpha functions. So with TNF-alpha functioning like that, and with the change in the TNF-alpha and IL-6 pathway, what happens is that the insulin now starts signaling the adipose tissue formation in the liver. It also increases more and more activity of the glucose transportase enzyme, and it makes more and more of the glucose transportase. So the synthesis is more, all of it eventually causes insulin resistance. So inflammation is also going to lead to insulin resistance. Similarly, the high TNF-alpha and IL-6 also cause the adipose tissue lipolysis, essentially cause increase in the circulating levels of free fatty acids. They cause atherogenic dyslipidemia. They, of course, affect the liver in a big way. So you'll find more gluconeogenesis, more insulin being formed, high levels of triglycerides, high levels of apolipoprotein B, essentially the main protein responsible for atherosclerotic plaquing. So there is an entire cascading event in the wake of inflammation and insulin resistance that causes the entire metabolic pathway, which is linked to diabetes and cardiovascular disease, which is essentially the high cholesterols and high triglycerides. I'm also going to talk about something called C-peptide, which I'm sure everybody already knows, but just very important, because when we're looking at diabetes reversal, we're looking at any form of disease reversal or remission, we have to look at what is it that I can handle. So there is something called C-peptide, of course, which is a short chain amino acid. It sort of connects insulin B and insulin A, which are required for the pre-insulin form of insulins. And this cleavage of the C-peptide causes the active form of insulin to be formed. And therefore, if people who do not have have very high, significantly higher levels of C-peptide, may not be able to reverse their metabolic syndrome condition. So we treat this, when we're looking at reversal or remission of diabetes, we treat the C-peptide levels as an important marker of whether the person can be taken in for remission or not. So progression, of course, into diabetes is not sweet. We already discussed that unsettled hyperglycemia or hyperinsulinemia, it causes insulin resistance. It causes more secretion of insulin by the beta cell, causing beta cell dysfunction. It causes the entire fuel homeostasis of the body is altered, resulting in beta cell hyperplasia, and of course hyperinsulinemia, which is also called pre-diabetes. If this is not corrected, the failure of the beta cells makes the secretion of insulin very little, causing the condition to progress into overt type of type 2 diabetes or diabetes mellitus. By the way, while we were discussing how inflammation causes diabetes or inflammatory factors cause insulin resistance to happen, we also realized that the only way to correct diabetes, or also diabetes, because there is more adipose tissue, mostly in people, even if it is visceral adipose tissue, there is only one way to correct it, and that correction is essentially through the nutrigenomic pathway, the pathway of nutrition, and that's where I'll take you eventually. But if you see, whatever markers have been done in a cohort studies, we've realized that the biomarkers of inflammation, which is the CRPs and the IL-6s, and the biomarker of lipogenesis, which is palmitoic acid, these are the two major biomarkers which develop in people who have diabetes or insulin resistance. And they, of course, cause the damage, the mitochondria and the cell membrane. We know that insulin and oral hypoglycemics can manage diabetes to some extent. They may, in fact, lower glucose levels to cause glucotoxicity, but they do not reduce the insulin resistance. They do not change the morbidity and mortality associated with diabetes. So pharmacology with oral hypoglycemic agents, except a few which we'll come to, most of them, and with insulin, which is injectable insulin, is essentially more about managing symptoms and managing the prophylactic condition, wherein you're trying to keep the blood sugars in a certain range and the HbA1c in a certain parameter. But it's not really the cure for diabetes. In fact, we always say that diabetes is no cure. And we do understand that there is a way to cure diabetes, and because I'm doing it myself, I'll be sharing that with you. Now, the cure for diabetes is essentially twofold, which is you decrease the carbohydrate intake extremely low, and you burn off all the excess lipogenic store in the body. And these two are the only things that need to be done, and that is what we do. So when we're talking about going back on diabetes or diabetes remission, we're talking essentially of a combination of a high-fat, low-carbohydrate diet combined with intermittent fasting. What happens is when you eat a high-fat, low-carbohydrate diet, when a patient or a client eats that, when they do that, they have reduced insulin production, causing the sugar and fat which is stored to be mobilized. Similarly, when they fast, it increases the insulin production, causing the sugar and fat that is there in the blood to be burnt and to be taken to the cells to be burnt via the mitochondrial pathway. So therefore, I know that, and this is what I'll show you what we've done here at one of the places that I work with. But what we've realized is that low carbohydrate diets, also called a well-formulated ketogenic diet. Now, I'm using the word ketogenic diet here, but it has to be used with a lot of caution, because there is a lot of information on ketogenic diet which needs to be carefully formulated, So it has to be a formulated ketogenic diet. It's not anybody going and just downloading a plan for ketogenic diet and following that, because there are many other clinical parameters that have to be taken into control. But having said that, when we look at a ketogenic diet, we also realize that traditionally, if you look at people, the traditional societies, there is no simple sugar or refined flour or refined food or refined carbohydrates in their diet. And therefore, although they still eat carbs, they do not have a high glycemic load, or they do not have enough evidence of diabetes and cardiometabolic syndrome. Therefore, it can be easily concluded that there is, of course, most important way of treating diabetes is to get into a well-formulated ketogenic diet and combine it with intermittent fasting. But if you are going to eat some amount of carbohydrates, then that type of carbohydrate also have to be defined and classified. This is just to explain you how the insulin dominance and insulin resistance really happens. And I will not go there in detail because there is limited time. So let me directly jump into my two strategies, which is intermittent fasting and the ketogenic diet. Now, you know what intermittent fasting is? Essentially a fasting for 14 plus hours, preferably for 16 hours. So essentially a person stops eating by 8 and then eats at 12 in the morning. So that he's eating between 12 in the afternoon to 8 in the evening, and not eating beyond that or before that, essentially being on fluids, and that's called intermittent fasting. And that's a very simple protocol to follow. The simple benefits of intermittent fasting that are classified by literature are that first, it increases the production of the somatotropic hormone. It facilitates the loss of visceral fat. So when we start ketogenic diet with intermittent fasting with patients, the first thing we see is loss of visceral fat that we can measure with the body composition analysis that we do. Also, it induces the cell. It's a bit like getting stem cells into mobilizing, because it's causing autophagocytosis, and it is sort of breaking down or killing the unhealthy or the dying and dead and decaying cells. It also, of course, reduces insulin resistance, and also reduces all forms of postprandial insulin, reduces appetite. It also reduces the fasting. It also reduces inflammation in a big way. So one of the part of the story is intermittent fasting. The second part is the ketogenic diet. Most of us understand what the ketogenic diet is. Essentially, the idea is to start using visceral fat as a source of energy and get the person or the patient into a state of ketosis. For ketosis to happen, of course, you have to limit the intake of energy, wherein the consumption of carbs sometimes goes as low as 5%. Essentially, we are relying on two pathways, which is the adenosine monophosphate kinase pathway and the mTOR pathway. Both of these pathways are extremely effective in everything you require to put the diabetes in place, whether it is increasing fat burning, whether it is improving insulin sensitivity, whether it is increasing apoptosis or killing the dead cells, whether it is improving the biogenesis of mitochondria, so more mitochondria formation, whether it is reducing inflammation, reducing tumor, including, we also use fasting mimicking diet for cancer. So it also reduces tumor growth, reducing the oxidative stress, of course, reducing the formation of lipoic acids, especially the palmitoic acid, and reducing macrophages and inflammatory markers. So all forms of inflammatory markers, which, you do the hsCRPs and ILS, these markers go down when the person is following the combination of ketogenic diet and intermittent fasting, and we're able to pull up the AMPK pathway. Now, the factors that besides when we are, of course, putting a person into remission for diabetes, the major role is of the diet and the fasting, but there are many more things that are required. For example, sometimes we do take certain pharmaceuticals, like we do manage the thyroid, we might use a statin for some time until the patient is off the high levels of triglycerides. Sometimes metformin is, of course, used. We also know that metformin is actually not an oral hypoglycemic drug. It's more a metabolic drug. But in addition to the pharmaceuticals, the main aim is to essentially use HFLC and intermittent fasting and then add on everything else that is required to cushion and improve it, which includes nutraceuticals, it includes herbs. We know that berberine reduces insulin resistance. We know that cinnamon reduces insulin resistance. We know that quercetin is very, very good. Yeah, I'm almost done. And of course, we know that, many things, for example, vitamin C, coenzyme Q10, resveratrol, zinc, ginseng, vitamin K2, all of them have a very serious role to play in reversal of cardiometabolic syndrome and specifically of diabetes. So therefore, when we're doing the entire story of reversal, we're also looking at the nutraceuticals, and we do nutrigenomics to determine the specific nutraceuticals that are required by that particular person. So I'm not going to take you through this core nutraceuticals, just to quickly put omega-3 fats, multivitamins, magnesium, D3, 90% of, by the way, urban global people have low vitamin D3, and the range is very poor, 30 to 100. We're looking at more than 70. So yes, there. And coenzyme Q10, vitamin K2, iodine, methylcobalamin, very important because we require the methylation of genes, and the MTHFR gene will only function when there's enough folate and vitamin B12. Homocysteine levels are also affected by them, so therefore very important. And this is my last slide. Essentially, this is what I want you to see. This is a little preview of what I have done, and I've done it with Dr. Alok Chopra. We're doing this together. Essentially, this shows you 20 odd patients that I've randomly picked up from the patients that we have, who we've put on the diabetes reversal program. It shows you how they have lost body weight. So you see percentage body fat loss, you see total weight loss in these people. Some people have been on a program for 2 months and others have been for 6 months or more. And you will see that these people have been able to reduce the HbA1c levels. They've been able to reduce the percentage body fat. They've been able to reduce their total weight. And of course, they've been off their medications. They've been able to get out of most of their medications, except, let me repeat, metformin, which may continue for some time. But people who've been on high doses of insulin are spared of that completely. So they do not require insulin as an injectable anymore after 2 or 3 months of the remission program. And therefore, diabetes is essentially a reversible condition. The way to do it is, of course, using the ketogenic. My study, this study of mine is essentially about using the ketogenic diet, the intermittent fasting protocol, and combining it with the right nutraceuticals, herbals, and support that is required, which is based on the genetics of that person, to achieve reversal of cardiometabolic syndrome, specifically of diabetes. But not just diabetes, you're able to reverse hypertension, you're able to reverse dyslipidemia, you're able to reverse autoimmune conditions, you're able to reverse neurological disorders. So that's my last slide. And I know that I'm short of time. There's a lot more I'd want to say, but thank you for the opportunity. I don't know if there are any questions, Dr. Telly. If there are, I'd be happy to answer. My details are with the organizers, of course. I practice in India. So if you have any person, who's sort of, coming in for any therapy specifically for diabetes, and they want to get out of the entire syndrome of metabolism, there is an option out, and it's not necessary that everybody has to be on pharmacological support. If we are able to tailor make a program for them, and that's what essentially I wanted to talk about. Thank you very much. Thank you so much.
Thank you so much for a very informative presentation, Ms. Manjari Chandra. Is there any burning questions? I think we can spend 2 or 3 minutes on any burning questions. No questions, I assume. Thank you very much.